we've got Catherine Turner from Hunter New England and Central Coast PHN, who's going to talk to us about outcomes-based commissioning, and I'm particularly interested in the decommissioning challenges. Thanks, Catherine.
Thanks very much, Chris, and I'd also... Oh, thank you. I'd also like to begin by acknowledging the traditional custodians of the land on which we're meeting today, and elders past and present. And thank you all for sticking around. I know I'm standing between you and lunch, so I will try to impart some of the knowledge. I'd also like to acknowledge Dr. Andrew Montague is part of our board, who I actually didn't know was going to be here today, so hello. What I'd like to do is provide a... Well, I'm doing it now. Is there a space bar? Oh.
You just have to, just press that one forward. Just takes a bit, maybe you have to point.
Sorry. Probably not. Oh, magic. Sorry, thank you very much. What I'd like to do is provide a very practical perspective of the journey of one primary health network in assessing its performance in commissioning primary care services using multiple types of data and in using those information for actual funding decisions at a local level, and sometimes those do result in decommissioning and termination. Sorry. When we were required to make some decisions about the outcomes that we were using for our funding and commissioning decisions, we have developed a health and wellbeing outcomes framework. This has enabled us to define the ways we are measuring effectiveness. This and the logic model, which we use to review the individual programs and services, is assisting us to be really clear about our expectations with the service providers, but this is very challenging work. The information about the outcomes framework and the patient and the logic are contained on our website, and you can access those by using those links. We use the quadruple aim framework when we're making some decisions. So the story of Hunter New England Central Coast Primary Health Network is that in 2015 we started with 4 contracts which we'd inherited from previous Commonwealth funded primary care agencies. These were predominantly block funded, and at the time they totalled about $10 million, but as of quite recently we've got over 80 contracts and totalling over $55 million, and it's increasing all the time. But we needed to be able to demonstrate that our program and style of commissioning is making a difference and is more effective than the way that services has been funded under previous models. And we were interested to find that at the time of the commencement, many of the contracts that we have been provided by the Commonwealth didn't contain measurable outputs, which made evaluation and potential decommissioning and being able to reinvest very difficult. In the first 12 months, we looked into each of the contracts and we were able to make some value for money assessments. Some of these were pilot programs which had been established, but over time it was very clear that they were driven by the wishes and the needs of the clinicians, not of the people that the service was benefiting. This made the need to decommission very clear, but gathering the data while designing a process for actual decommissioning takes time. I can report that on the first occasion it took months of assessment, consultation, weeks of planning, culminated in a 3-minute phone call where the director of the service responded with, "Yeah, fair enough, I wonder why it took so long." But all of these situations are not resolved that easily. So in order to move from traditional funding to a new way of commissioning of services, Hunter New England Central Coast has worked hard with the service providers to understand why this change is necessary. As each of the services is reviewed and potentially redesigned, we've worked with everyone involved, including the users of the program, to develop measurable outcomes and outputs, and inserted these into the individual contracts. We've also moving to a payment for services delivered rather than a funding model which, frankly, in some occasions was being treated like a no-strings-attached donation. This isn't to say that the money was being misappropriated, but it was difficult sometimes to see the alignment between what the funding was for and what was actually being delivered. So each of these improvements in this process requires careful consideration. I think Lucille described some of the complexities involved in this already. The need to consider challenges of appropriate data collection, taking into consideration the impact on the service provision and the potential costs of collection, the problems with interpretation of the data, the challenges of the validity of that interpretation, and the risk of the service providers placing more importance on data and reporting than providing high quality services have all compounded these actual aims. The latter, which is really what Lucille was also speaking about, which is spending more time collecting data than delivering service, has been described as target myopia. We've certainly been criticised for that, and we are really trying to focus on both the collection of that information and the impact on the consumer and the service provider. At worst, there is a risk of active manipulation of the data to ensure that payment is provided and the service remains viable, and that's obviously not an intended consequence. What has become clear to us, though, is there is much information available to primary health networks from a range of sources, including the population health data, which has always been there but not always well used, data which is collected by general practices, which we're now getting much better access to and we're much more able to interpret and to make good use of, and data actually provided by our commission services, which is now contributing to the population health data at a local level. We've worked across the program. There's also a great willingness from our service providers to participate in this sort of activity for a number of reasons. Some of them want to demonstrate their own efficiency and levels of measures of quality, but others really understand that working with patients to work out what's important to them can actually change the way that clinical care is delivered. And for us, that's really been quite an interesting change. We have also experimented with payment we've made actual payment for outcomes with our integrated care program. We've worked with our service partners, We've worked with our service partners to design and to work out which of the patient-reported outcome and patient-reported experience measures that they would be prepared to link some of their service payment to, should there be an agreed improvement in those measures. It might sound simple, but as we've already heard today, it's just not. It's been a 3-year piece of work, and we're now testing the impact of the services by real-time payment on outcomes. I must say we've kept the proportion of the payment quite minimal, and we've also made the outcomes, the measures, something that they were pretty sure that they would achieve. We want to test this, but we want to make sure that it's obviously not going to put our service providers in a position of financial risk, too much financial risk. Unfortunately, we couldn't replicate this across all of our programs because the other thing that we've learned is this costs a lot of money. It takes a long time to do. Finding a way that people are prepared to collect these outcome measures is quite difficult. Some of these are, this slide, for example, is something that comes from a third-party contractor who collects the information from the tablets that the service providers are using, delivers it back to us and the providers in real time. We get de-identified information, but they get real information, and they also get some benchmarking of their performance against the other service providers who are working in the program. But we would not be able to do that as much as we would like to do. So, decommissioning. In some circumstances, when you spend more time on looking at the measurable outcomes and the purpose and the performance of the service, this has actually resulted in the need to decommission a service. In one case that we've been through, a new service was funded and established as per the contract. It was innovative and it looked like it was really going to be something that everybody was keen to be involved in. During the course of the implementation, there were partners who were working together. There was a breakdown in that relationship. Plus, not very helpfully at the same time, New South Wales Health funded a similar program to do exactly the same work in exactly the same location. But for us, the lead contractor stayed very much in touch with our commissioning coordinator at the time, and we revised the scope, the pathways. We tried all sorts of ways to make this work, but finally they asked for a meeting and they came to us to say, we can't deliver on this contract, it's not right for us to keep accepting the money. And in that situation, we paid them for the cost of the attempted establishment, and we found an alternate use for the funding. On other occasions, when we've looked at contracts that have been in place for a very long time, particularly, if they've been block funded without clear deliverables, when we put the deliverables in place, well, the contractor worked really hard to provide that service. They actually decided in the end that the increased scrutiny and the requirement to deliver what was required in the contract was a bit too much for them, and even though we offered to roll the contract over again, they decided they didn't want to deliver the service anymore. So that's a risk that we obviously didn't want, but it is a reality of what happens. And then in our third example, we had a much closer look at the outputs of a block-funded service again, which had been in place for many years. And much closer scrutiny, including by the service provider and our other clinical partners, identified a model of care which was deemed not to be safe or appropriate. After many attempts at revising the contract specifications to identify a safer model or a more appropriate target population, the final outcome was contract termination. In this case, the usual decommissioning and transition approaches were implemented. The provider was funded for a short period to transition existing clients to a more appropriate service or to complete. That one we've just finished up. But it does raise some other challenges of when you decommission a service and what do you do with the money. So I've included some snapshots of the beautiful Hunter New England Central Coast region, just in case you want to come and visit us. Or you'd like to come and work for us, that's another story. Decisions to terminate services or change contractors are not to be taken lightly, and we don't. We've learned that this approach, we have learned the need for careful planning, and for this we use a risk management approach. We prepare communication with key messages for a range of stakeholders, including those who could be potentially contacted should a complaint arise, and we proactively contact local politicians and others when these situations occurred. For others in the room, we've just reviewed the Deloitte's review of the procurement of the Headspace Centre in Victoria, and we're utilising that information to further improve our processes. By engaging in effective and evaluation and contract management in the same way that we would hope would happen in human resource management, there should be few or no surprises. We ask all the service providers to include a transition out plan as part of the contract deliverable when the contracts are implemented. These can be a bit sketchy initially because people never think that things are going to end, but in fact we know that that's not the case. But we have been using them to refine the implications, and it's hugely assisted us as the plans have identified details which wouldn't have been clear to us in the first place. As I've said though, the other consideration relates to funding. To ensure the impact on the patients in the service is minimalised, a transition period is often required. Planning for the funding is difficult, but some does need to be set aside so that we can be sure that patients don't fall through the cracks when services that they're being very happily using are terminated, or if there's a change of service provider. On a few occasions, which I've mentioned, the result was that the funding then became uncommitted. This is possibly the number one challenge for a service funder, which is very different for a service provider. So money in the bank is not what we're after. To use these funds within the funding period, we use a range of services, including capacity building or innovation grants. We look to other services to implement short-term increases, or we enter into a negotiation with the Department of Health to see if we can carry over the funds. So finally, the increased focus on measurable outputs to enable an assessment of value has led to an improved understanding of our role as commissioners. The outputs can be session-based, clients who would be supported by a service or other measures. We now have a strategic indicator which says that 80% of all of our contracts will have measurable outputs. Again, that seems fairly simple and obvious, but isn't the case, or wasn't the case, and it's something we're working through. With improved confidence and understanding about the services being funded, we're able to ensure that measures are in place to demonstrate accountability. We have seen improvements in the way services are delivered. For example, payment for new patients coming into a service has meant that providers have had to assess the number of people who are on their books. And in some cases, they've been providing a service for 8 years for people. And so we've now asked that they work through those, reassess all of those patients and consider how they may bring on new people. Where to next? We will continue to work hard on the monitoring and evaluation and the performance of our commissioned services. We understand the challenges of decommissioning. It's not an option that we take lightly, but one that we should absolutely anticipate. We've improved our processes for communication and risk management, and in regards to decommissioning, we're better able to manage transition of service and alternate use of the funding, which ensures that we are making the best use of the funding for our community. I'd just like to draw your attention to the photo. That's about 12 months ago, and how brown it was around Tamworth. It hasn't rained since, and we're really struggling with bushfires today. So I'd like to pass on my concerns, I suppose, for the number of people in our region who are really displaced by the bushfires today. So thank you very much.